Let's talk about uterine sarcoma from Berek and Hacker's textbook. Uh, uterine sarcoma are rare mesodermal tumors that accounts for 30 to 7% of uterine cancers. They are heterogeneous group of tumors. Individuals experience with each lesion is limited. Historically, uterine sarcoma have been classified into carcinosarcomas, that is accounting for 40% of cases, Leiomyosarcoma, that is 40% of cases, endometrial stromal sarcoma, that is 10 to 15% of cases, undifferentiated sarcoma, that is 5 to 10%. Although carcinosarcoma have been reclassified as metaplastic form of endometrial carcinoma, they have been included in the uterine sarcoma in most retrospective studies. Not included in clinical trials of endometrial carcinoma, leiomyosarcoma and carcinosarcomas have a higher incidence in African American women in the United States. Most subgroups behave in an aggressive manner and have a poor prognosis. This is a very aggressive tumors. This is a very poor prognosis with high rate of local recurrence and distant metastasis. Pelvic radiation has long been believed to predispose to the subsequent development of uterine sarcoma. Is there any history of pelvic radiation in history? You should ask this patient. But Finnish researchers have shown that the use of combined HRT in post-menopausal women for 5 years or longer is also associated with increased risk. Those have been using combined hormone replacement therapy in postmenopausal women for 5 years or more, that will associate with increased risk of development of carcinosarcoma, leiomyosarcoma, endometrial stromal sarcoma. That is, another risk factor is pelvic radiation, and another risk factor is combined HRT for more than equal to 5 years. A nationwide cohort study of all Finnish women 50 years of age or older who had used estradiol and progesterone therapy for at least 6 months was performed. There are 2,043,857 estradiol therapy user is identified from the National Medical Reimbursement Registry. Their incidence of uterine stromal and leiomyosarcoma was compared to that of the background population with the aid of the Finnish Cancer Registry. The exposure to estradiol and progesterone therapy for less than 5 years was not associated with any significant increases, but the standardized incidence ratio 5 to 10 years of use is 2 and 10 year or more is 3. Okay, there is some risk in HRT. Gelman quiz reported that endometrial carcinoma and malignant mixed Mullerian tumors have a similar risk factor profile, which is compatible with hypothesis that pathogenesis of these two tumors is similar. Criteria for histopathological classification of sarcoma have been changing. Such lesions should be reviewed by an expert gynecological pathologist. Much less emphasis is placed on much mitotic count less. That was the much less emphasis is placed on mitotic count than was previously the case. Smooth muscle tumor, that is leiomyosarcoma, which must be distinguished from the cellular leiomyomas and atypical leiomyoma, occur most commonly in the age group of 45 to 55 year age group. In the SEER study of 1,396 patients, the median age of the patient was 52 years. Leiomyosarcoma usually arises de novo from uterine smooth muscle, although rarely they may arise in pre-existing leiomyoma. Subset of leiomyosarcoma usually they arise from the de novo from the uterine smooth muscle, although rarely they arises from the pre-existing leiomyoma. Very rare, very rare, 0. less than 0.1%. Then a subset of myoma with the deletion of specific portion of chromosome 1. Remember, the chromosome 1 has specific cellular morphology and a genetic transcription profile similar to those of leiomyosarcomas. A subset of myomas, those having a deletion of specific portion of a chromosome number 1, has a specific cellular morphology and a genetic transcription profile similar to those of leiomyosarcoma. Thus, cytogenetic may help in identify this exception. Cytogenetic, this, okay, remember. Then, thus, you should do a cytogenetic. Thus, cytogenetics may help identify these exceptions to the rule, possibly allow prediction of malignant progression. A review of 1,432 patients undergoing hysterectomy for presumed fibroid at the University of Southern California revealed a leiomyosarcoma in the hysterectomy specimen in 10 patients. The incidence increased steadily from the fourth to seventh decade of life. Most leiomyosarcoma are accompanied by pain and a sensation of pressure, abnormal uterine bleeding, lower abdominal mass. Rapid enlargement of a fibroid is possibly the sign of malignancy. Remember this thing: rapid enlargement. Rapid enlargement of a fibroid is a possibly the sign of a malignancy. Rapid enlargement should be there. Rapid enlargement of fibroid. Remember this important point: rapid enlargement of fibroid is possibly a sign of malignancy. Then, a few patients may have signs of metastatic disease such as persistent cough, back pain, ascites. Remember this: persistent cough, back pain, and ascites. On physical examination, it is impossible to distinguish between leiomyosarcoma from a large leiomyoma. Pap smear are unrewarding. Uterine creatinine are diagnostic for only for the 10 to 20% of tumor that are submucosal. Diagnostic usually not made before surgery. Uterine smooth muscle tumor of uncertain malignant potential, that is STOMP, represent a subcategory of uterine smooth muscle tumor which clinical behavior poorly understood. A series of 45 patients was reported from MD Anderson Cancer Center 2009. Their mean age is 43 years with range of 25 to 75 years with mean follow-up is 45 months. 3 recurrences were seen. The recurrence rate was similar to the patient having myomectomy or hysterectomy. One of the recurrence was leiomyosarcoma, but all the three patients were alive. Disease-free mean follow-up 121 months. IV leiomyomatosis is a rare, relatively benign uterine smooth muscle tumor in which much of the tumor is present in artery or may arise from vein. It may extend robbery cards beyond the uterus to parametrium, occasionally into the vena cava. Some patients may survive prolonged period in spite of incomplete dissection of disease. High level of estrogen progesterone receptor in the some tumor. Leiomyomatosis peritonealis disseminated is a condition in which numerous nodules of histologically benign smooth muscle tumor present in the peritoneal surface. It frequently associated with term pregnancy or with use of oral contraceptive. Regression may occur after the termination of pregnancy. The tumor limited to the uterus, less than 5 cm size 1A, more than 5 cm is 1B. The tumor limited to the uterus, then stage 2 is tumor extended to the pelvis. That is adnexal involvement, tumor extend to extrauterine pelvic tissue. Adnexal, then extrauterine pelvic tissue. There is 2A, 2B. Limited to uterus, size is less than 5 cm. 1B is more than 5 cm. Stage 2 is tumor extended to the pelvis. Adnexal involvement is 2A. Adnexal extend to the extra uterine pelvic structure is 2B. Stage 3 tumor invade abdominal tissue, not just protein in the abdomen. One site structure, more than one site. 3B metastatic pelvic and parotid lymph node is 3C. Stage 4 invade the bladder and rectum, distant metastasis. Stage 4B. The benign metastatic leiomyoma is a rare disorder characterized histologically benign smooth muscle tumor that originated in the uterus, spread elsewhere, usually to the lungs. Conversely, existing regarding whether the lungs lesion represent metastasis of benign uterine or primary tumor of synchronous metachronous tumors. How staging already done. The treatment surgical. The only treatment any proven curative value for the frankly malignant leiomyosarcoma is surgical excision. This typically involves total abdominal hysterectomy, as well as helping oophorectomy, debulking of any tumor outside the uterus, including any enlarged lymph nodes. In a young patient, it is reasonable to preserve the ovaries, particularly if the tumors has arise in a fibroid. Tumor marcellation increase intraperitoneal dissemination and adversely affect the survival. Lishani et al. Report 8 young patients with diagnosis of leiomyosarcoma after myomectomy who are followed up conservatively. All are nulliparous and all had no evidence of disease on ultrasonography, hysteroscopy, chest radiography, pelvic and abdominal CT scan, and MRI. The mean mitotic count of leiomyosarcoma was 6 per 10 hour hyperfilled with range of 5 to 33%. Median follow-up 43 by 3. For leiomyosarcoma, GOG study of 59 patients reported positive lymph node only 3.5% of patient, positive wasing only 5.3%, adnexal involvement only 3.4%. 71 patients with leiomyosarcoma confined to the uterus and cervix. Memorial Sloan Kettering group reported ovarian metastasis in 2 patients. Lymph node metastasis known. 3 of 37 patient extravascular disease has positive or clinically suspicious reported pelvic and paraortic lymph node involvement in 21 patients who underwent complete surgical screening. The SEER study reported lymph node metastasis 23 of 348 patients, that is 6.6% who underwent lymphadenectomy, but performance of lymphadenectomy is not associated with improved survival because most lymph node metastases are found in patients with Arban's disease. A possibly secondary site reduction of leiomyosarcoma was reported from the Johns Hopkins Medical Center. In recent review, 128 patients with recurrent uterine leiomyosarcoma, researchers reported prolonged survival in selected group who had a prolonged progression-free survival. Isolated site recurrent disease amenable to complete dissections. Neither chemotherapy nor radiation therapy was beneficial. The most active drugs include doxorubicin, ifosfamide, paclitaxel, docetaxel, and gemcitabine. In the GOG trial, leiomyosarcoma had a 25% overall response rate to the doxorubicin, partial response rate to ifosfamide, doxorubicin. Remember these two drugs: doxorubicin, ifosfamide. Partial response to cisplatin, partial response to cisplatin for paclitaxel. There are 3 complete response, whereas 8 patient at least. Because of propensity of early hematogenous spread, the adjuvant chemotherapy after hysterectomy to eliminate the micrometastasis is an alternative concept. A large study, that is 1042 patient uterine sarcoma, recorded in the Cancer Registry of Norway from 1956 to 1992, reported no change in the survival, 5-year survival rate after the introduction of chemotherapy into the treatment protocol. However, a prospective study of 25 patients with completely resected stage 1 to 4 leiomyosarcoma from Memorial Sloan Kettering Cancer Center reported 2-year progression-free survival rate superior to the historical control for adjuvant docetaxel and gemcitabine group. The latter was given a dose of 900 mg on day 1, day 8 docetaxel 75 mg per meter square on day 1, day 8 every 3 weeks for 4 cycles. A prospective multicenter phase 2 trial, 46 evaluate patient with disease limited to the uterus treated with 4 cycle of adjuvant gemcitabine plus docetaxel followed by 4 cycle doxorubicin. International randomized phase 3 trial observations versus adjuvant therapy is ongoing with primary endpoint being overall survival. For patients with metastatic leiomyosarcoma, GOG reported objective response in 15 of 42 patients treated with gemcitabine plus docetaxel. The complete response rate was 4.8%. Partial rate was 31% with additional patient of stable disease. The combination of docetaxel and gemcitabine has been reported to be active as a second-line therapy for patients with metastatic leiomyosarcoma. In study of 48%, 90% whom progressed following doxorubicin-based chemotherapy, Hensley et al. Reported a complete response in 3 patients, partial response in 15%, for an overall response by 53%. Additionally, 7 patients had a stable disease. 50% who were treated previously with doxorubicin had a response. Progression was 5 to 6 months. Radiation therapy, post-operative external beam pelvic radiation, and no proven benefit. Although it has been thought to be improved tumor control in the pelvis, the recent randomized clinical trial adjuvant external pelvic radiation versus observation with non-metastatic leiomyoma revealed no benefit in terms of local control. Data patient with typical stage 1 leiomyosarcoma study SAR data analysis. The 5-year survival rate is 76.6% with stage 1 disease 48.4, those with stage 1B. Although cervical involvement is not a part of the figure staging system, the 5-year survival rate without cervical involvement significantly different. Significant prognostic variable multivariate analysis using micro array of 84 uterine myelosarcoma researchers have been identified 2 different prognostic groups. Good prognostic tumor were less than 10 cm diameter with myotic index less than 20, myotic figure for 10, hyperfull, negative Ki67, positive or negative BCL2 immunostaining. Poor prognostic tumor is more than 10 cm diameter, had a higher myotic index is more than 20, 10 hyperfull, positive Ki67, negative BCL2. Good prognosis is less than 10 centimeter diameter, mitotic index is less than 20 for 10, high for filled, negative for Ki67, positive for BCL2. Negative for Ki67, positive or negative for BCL2 immunostenting. And 160 patient leaving from Boston institution reported the tumor size more than 10 centimeter, mitotic count 25 in 10, however, greater over an independent prognostic factor. The summary of the management: the only proven benefit for patient with leiomyosarcoma is total abdominal hysterectomy. Ovaries should be normally be removed in postmenopausal women. Systematic lymphadenectomy appear to be of no value, but any enlarged lymph should be removed. This patient should be entered onto a clinical trial of new therapeutic agent, particularly docetaxel and gemcitabine if possible. Endodermal stromal tumor. Okay, this is the carcinosarcoma. This is called malignant mixed mesodermal tumor or carcinosarcoma, usually occur in an older age group, most patients being postmenopausal. They grow rapidly, usually represent with postmenopausal bleeding, pelvic pain, symptoms of metastatic disease. Most of the patients have an enlarged uterus. Tumor produces through cervical os like polyp in approximately half of the patients. Extrauterine disease is found in up to one-third of cases of presentation. Uterine curetes usually detect malignant tissue in the uterus, although determination of the exact nature of the tumor may require histological examination of the entire specimen. Carcinosarcoma stays as same as carcinoma. This malignant mixed mesodermal tumor or carcinosarcoma usually occur in an older age group, mostly in the postmenopausal. They grow rapidly, present postmenopausal bleeding, pelvic pain, symptom of metastatic disease. Most of the patients have enlarged uterine tumor protrude through the cervical os like a polyp in approximately half of the patient. 50% patient there will be a polyp that is protrude through the cervical os. Extrauterine disease is found up to one-third of the case of presentation. Uterine curetes usually detect malignant tissue in the uterus. So you can go for a biopsy. For the confirmation of the tissue, you should do a complete entire specimen histopathological examination of the entire specimen is necessary. Carcinoma stays same as carcinoma. This is a convincing evidence that most but not all uterine sarcoma, carcinosarcoma monoclonal tumor, most are monoclonal but not all tumors, and really metaplastic carcinoma. The behavior of this tumor is similar to that of high-grade endometrial adenocarcinoma. They should manage as such. Metastases are usually from the carcinomatous element, and the sarcomatous element is believed to be derived from as a result of de-differentiation of the carcinomatous component. The heterologous differentiation include rhabdomyosarcomatous differentiation is not uncommon in malignant mixed mesodermal tumor. Occasionally, fewer heterogeneous sarcoma have been reported. 37% of patients with carcinosarcoma history of prior pelvic radiation. Remember, this history is very, very important. Pelvic radiation history you should ask those having your diagnosis carcinosarcoma. 37% of patients already have a history of prior radiation therapy. Such case tend to be occur in younger women containing heterologous element, tend to found in advanced surgery. Thus, carcinosarcoma should undergo a total hysterectomy, bilateral salpingo-oophorectomy, and surgical staging in the same manner as high-grade endometrial carcinoma. GOG trial reported clinical pathological study of 301 carcinosarcoma in 1993. Adnexal metastases are present in 12% of patients. Lymph node metastasis 18%. Positive peritoneal cytology 21%. No mental biopsy were taken. California study 62 patients with carcinosarcoma apparently confined to the uterus. Reported occult metastasis 38%, and nexal metastasis 23%, pelvic positive node 31%, positive paraortic 6%, omental involvement 13%, positive peritoneal cytology 29%. Cytoreductive surgery with the goal resecting all macroscopic disease has been reported to be associated with the improvement of overall survival in patients with advanced uterine carcinosarcoma who go for a cytoreductive surgery. Chemotherapy, there are a number of activations include cisplatin, carboplatin, anthracycline, EI-fosfamide, paclitaxel, cisplatin, carboplatin, gemcitabine, docetaxel in leiomyosarcoma, gemcitabine, GD. As these are relatively uncommon tumors, study have generally been small and patients' accrual has been low. For cisplatin, 50 mg milligram square every 3 weeks. In the GOG report, complete response rate is by 8%, partial is 11%. No, ifosfamide is an active agent for this tumor. GOG demonstrated 9 response among 28 patients. All small improvement prognosis feasible noted with the addition of cisplatin to ifosfamide in phase 3 GOG trial. But added toxicity may not justify use that combination. GOG evaluated paclitaxel in 44 patients with carcinosarcoma of the uterus. 4 patients, 9.1% had a complete response. 9.1 had a partial response. GOG subsequently reported result of randomized study comparing ifosfamide alone versus ifosfamide paclitaxel in 117 patients with advanced uterine carcinosarcoma. They reported a response rate of 29% with ifosfamide alone, but 45% with the combination. The odds of response certified by performance status were 2.21 times greater in the combination form. So medial progressive survival compared with ifosfamide and only 3.5 more. Okay, so ifosfamide paclitaxel combination is better. Number of phase 3 trial have reported high response rate carboplatin and paclitaxel in patient advanced carcinosarcoma. Very important. In prospective phase 2 study, 65 patients completely resected clinical stage 1, stage 2 disease with 3 cycle of ifosfamide cisplatin. Advanced adjuvant therapy for early stage disease. A large randomized trial comparing the whole abdominal radiation with 3 cycle cisplatin. Ifosfamide mesna. Patients with stage 1 to 4 radiation, the estimate crude probability recurring with 5 years. 50% whole abdominal radiation. With no gross residual disease, adjuvant pelvic radiation sandwich between ifosfamide alone and ifosfamide cisplatin. Several non-randomized have been suggested radiotherapy reduce local recurrence. EOT's randomized study stage 1 to extra pelvic radiation decrease pelvic relapse but does not improve over survival. Summary of the management of carcinosarcoma suggests that carcinosarcoma of the uterus should manage full surgical staging, resection, any gross metastatic disease. Post-operative radiation should be tailored to the operative finding. Adjuvant therapy, cisplatin, epirubicin, ifosfamide based combination, carboplatin, paclitaxel may be beneficial based on small phase 2 trial. 33 prognosis, 300 milligrams recurrence rate is 53%, 44 homologous, spectral secondary rate to progression survival. And nexal spread, lymph node metastasis, tumor size, vascular sparing invasion, depth of myomicral invasion, positive petrol cytology, histological grade, cell type. The significant prognostic at nexal spread, lymph node metastasis, cell type, and cell grade. Better survival have been reported in smaller study following surgical staging, tailor radiation, adjuvant chemotherapy. The role of adjuvant chemotherapy after surgical staging, tailor post radiation, most of the randomized trial.